we have two guest speakers on hidden costs, unconscious bias in the healthcare workforce. So our first speaker will be Ava Black. She's currently an assistant professor of medicine here at Yale. Her scholarly interests focus on the promotion of workplace diversity and inclusion through several avenues, including spearheading minority recruitment efforts, facilitating training sessions on bias, and exploring effects on race on underrepresented minority positions. In her role as the Associate Program Director for Diversity and Inclusion for the Yale Primary Care Program, she supports residents who identify with vulnerable populations, and she develops curricular design to enhance cross-cultural knowledge. We also have Dr. Boatright, who many of us know from the University Department. He's formerly a Robert Wood Johnson Foundation clinical scholar here at Yale. Prior to his fellowship, he trained at Denver Health Emergency Residency Program. He focuses on diversity in the healthcare workforce and racial ethnic disparities in healthcare treatment and outcomes. He's had several publications over the last year, including JAMA and JAMA Internal Medicine. I'm going to start with Dr. Black. Dr. Black, thanks.
All right, good morning, everyone. I'm really thrilled to be here, and thank you for the kind introduction and the invitation. Both of us feel so strongly about healthcare workforce diversity and inclusion, and so we're really grateful for the opportunity to have a chance to share some of our work and share some of our thoughts about how to move forward with these important topics. Neither of us have any disclosures to report. And these are our 3 learning objectives for the morning. So by the end of the session, we hope that we'll be able to get into some of the scope of unconscious bias in the workforce. As we go through different cases and examples, we hope that each of us can move forward in terms of understanding some of our own personal blind spots. And then lastly, kind of figuring out how we both individually and also institutionally can move forward to mitigate some instances of bias and become a more inclusive community. So this is the outline for our session. I'll start off by giving some background and definition of terms, and then we'll go into a study that both Dr. Boatright and myself were involved in, looking at the workplace experiences of underrepresented resident physicians. Then we'll talk about why this is even something that is worth discussing in a grand round setting, why is it something that matters to us as healthcare professionals, and lastly, thinking about strategies to improve. So in terms of the scope of the talk, I just think it's important to make clear from the beginning that when we say the word diversity, there's so many different identities that fit under that category, including but not limited to race, ethnicity, nationality, citizenship, gender, religion, ability, on and on and on. Most of the work that we've done in the study that we'll highlight for today really focuses on race and ethnicity, but that is by no means to lessen any of the other very important forms of diversity. So starting with background, just to get us on the same page in terms of some key definitions. So a lot of what we'll be discussing today stems from the concept of implicit bias. And many of you are probably familiar with the term microaggressions, which is a concept that was first developed by a psychiatrist by the name of Chester Pierce way back in the 1970s. But it's really only been in the last few years that scholars have taken a renewed interest in further developing this concept. And I think a helpful way to think about microaggressions are these brief, sort of everyday exchanges that can send denigrating messages to people as a result of their affiliation with a particular social group. And so implicit bias is really the mental process that's happening, whereas microaggressions are the behavior. And I think something that's really important to note is that microaggressions are often not intentional, they're happening subconsciously, they're automatic. So it's not about people being necessarily racist or sexist, but nonetheless, these kinds of small interactions can have a large impact. One way that I think to distinguish explicit bias, which I think we're inherently more comfortable with identifying, if we hear someone call a person a racial slur, all of us can look at that and say, that's bias, that's explicit. But I think implicit bias is often a lot more nuanced. And something that's key is that oftentimes our own personal viewpoints on a particular social group can actually stand in contradistinction to the implicit bias that's happening that we are not even aware of. So for example, I tell this story often. I grew up in a family where my parents are Ghanaian, and I am therefore a first-generation American. And the gender roles in my family growing up were very sort of set in terms of what women should be doing, being more tied to domestic responsibilities. whereas my brother would be like sitting on the couch while I'm helping my mom with cooking dinner. And as a result of that, I grew up with these very clear, explicit views that women can do whatever they want in terms of career advancement and professional opportunity. And in spite of that, oftentimes I find myself in my role as a primary care doctor, if a patient is coming into my clinic and they start talking about their surgeon, my next question to them is, what is his name? And before even thinking about it, I've made this association that surgeon equals male, even though that couldn't be further from what I believe in terms of different genders capacities. So hopefully that serves to illustrate some of the differences that we're talking about in terms of explicit bias, our consciously held views versus implicit bias. In terms of the science, so many social psychologists have looked at this, and I think what we know so far is that unconscious bias seems to develop at a pretty early age, starting in early adulthood and continuing to develop in early childhood and continue to develop in middle childhood. And they've done these studies where if you take children even as young as 7 years old and you give them these hypothetical cases where you're essentially asking them to rate the pain level of children of different races, things like hitting one's head or biting one's tongue. Children, both Black and white children, will say that African American children experience less pain from the same insult. And that study, of course, is very interesting, given that all the data we know in terms of people of color being undertreated for pain. So it's something that starts very early. We also know that there seem to be real world effects on behavior. And so even outside of having explicit bias, if you, for example, have an anti-Hispanic bias unconsciously, they have done studies where they show that the amount of eye contact that you have in interpersonal communications is decreased compared to someone that you don't have that bias toward. And then this last point I think is really interesting, and I think it still needs further development in terms of our understanding of how flexible our unconscious bias is. I think oftentimes when we have these conversations, people want to know, well, what can I do? How can I improve this bias that I don't even know about, these blind spots I have? And something that we do know is that there does seem to be different strategies that we can use to actually mitigate the bias. There are studies where looking at college-age students, if you expose them to counter-stereotypic illustrations. For example, in my earlier example, if you take a bunch of high-powered women who are CEOs of different companies, very advanced in their career, and you repeatedly increase that exposure to a group of people who have an unconscious bias that women can't achieve highly in their profession, over time, that implicit bias will lessen. I think this is important too in terms of thinking about what are the triggers for implicit bias. So cognitive overload, sleep deprivation, stress, of course, none of which we ever have in the field of medicine. So clearly these are things that we all deal with on a day-to-day basis. And I think it's important to recognize that in healthcare, we're particularly susceptible to unconscious bias because so many of us have demanding schedules and deal with a lot of stress. So now moving on to some data. So underrepresented in medicine, or URIM, is a term that I think is helpful in terms of understanding the racial ethnic aspect of diversity and inclusion in medicine. And the AAMC defines it this way: those racial and ethnic populations that are underrepresented in medicine relative to their numbers in the general population. And so generally that refers to Hispanic and Latinx, African American, American Indian, or Alaskan Native origin. And I think it's interesting when we think about this concept too, because clearly other racial groups that may not be underrepresented in medicine can still absolutely be prone to unconscious and explicit bias. However, for the purposes of the data that we have and the way we sort of group race as a social construct, we often have these groups as far as the groups that are targeted as underrepresented. Some more data here. So on your left, we'll come up with a pie chart of the US population and the racial ethnic breakdown. And then I want you to pay attention to the right side of the screen, which will show the racial ethnic breakdown of the physician workforce. And a couple of points that I'd like to draw your attention to. As you can see, African Americans make up approximately 13% of the US population. But when you're talking about the slice of the pie in our physician workforce, that number is only 4%. Similarly, for Hispanic or Latino folks, 18% of the US population, but then only 5% of the physician workforce. And so this is what we're talking about when we talk about a representation issue. Interestingly, not only do we know that there's this gap when you're talking about the overall representation in the population to practicing physician level, but also we note that as you move from the kind of medical school to GME to being an independently practicing physician, the numbers also decline. And so it's a little unclear exactly what is causing this trend, but we know that there appears to be a drop off as we move through the different stages of the career trajectory. Unless we think these are national statistics that have no bearing to our day-to-day, I wanted to show you a graph that highlights statistics from Yale. This is taken from a few years ago. To orient you on the graph here, on our x-axis, we have the med student level, then resident fellow, then faculty. Y-axis, you have percentage. White or Asian, which are just grouped as the groups that are not underrepresented in medicine, and then are in the sort of the darker yellow color, and then the lighter yellow represents African American, Hispanic, Latino in the orange color. And as you note, as you go from the med student to resident fellow to faculty level, the degree of representation in terms of including underrepresented groups declines quite dramatically, to the point that once you're at the faculty level at the Yale School of Medicine, you're talking about 6% of people who are comprised of underrepresented groups at the faculty level here at Yale. And now moving on to the study I alluded to earlier to further flesh out some of these issues. So there's been a lot of work by researchers over the past few decades looking at the experiences of underrepresented in medicine physicians. And our own Marcela Nunez-Smith, who is a professor here in the section of internal medicine, has really spearheaded a lot of this work. As you can see by the multiple citations, there really is a lot of consensus that folks who identify with these groups experience many suboptimal workplace experiences, including lower career satisfaction, feeling like they're not adequately recognized for their work, experiencing increased scrutiny, and even feeling like there are many instances of racial bias in their academic environments. So something our team was really interested in looking at is that right now there's a bit of a black hole in terms of the resident experiences in medicine. And more recently, there have been a few other studies that highlight harassment and discrimination, but we're really interested in looking at URIM residents and seeing how they characterize their experiences, because a lot of the studies I mentioned earlier were really looking at independent physicians who had completed their training. And it seemed to us that residents are a particularly vulnerable group, and we wanted to get a sense of their stories. And so we conducted a qualitative study using a semi-structured interview format where we targeted underrepresented in medicine resident physicians. So for the purposes of the folks that we sampled were Black, Hispanic, and Native American. And then we continued to interview until we reached thematic saturation and ultimately analyze our data according to the constant comparative method in which we were looking at our data to extract recurrent themes. This is a bit of our interview guide. Tell me a little bit about your experience as a resident, asking to recall a time where they felt race or ethnicity may have affected their experience as a resident, and so on. And so this is our paper. It was published last year in JAMA Open. We ultimately interviewed 27 minority residents. Myself and Dr. Boatright were the folks on the team who were interviewing in a one-on-one format. Our sample was 56% female. The majority were African American, and we had a wide range of specialties represented and a number of different institutions. And we just wanted to take a little bit of time to talk about the three major themes that emerged as we analyzed the data and heard the stories of these underrepresented medicine residents. The first was common racial bias. The second is role of race ambassador, which we'll define a little bit later in the talk. And then lastly, what we termed a pressure to cover racial identity. So we certainly noted a range of bias that these residents were reporting, from the microaggressions to quite explicit forms of bias. In general, however, most of what the residents would share were instances where it was either unintentional or in some cases very nuanced kind of exchanges. And one such story, which was quite common across the folks that we talked to, was what we termed assumptions of lower status. And this was the idea that for many of our residents, despite wearing their ID badges, having a stethoscope around their neck, wearing a white coat, they were nonetheless often mistaken for other people in the hospital who were not part of the care team, whether it was folks who are in nutrition services, environmental services. And again, this was despite having all these other associations that they were trying to assert their belonging as a physician. And so this was a quote at the top by one African-American resident: "I've never been called transport so many times in my life." The other quote here is, "I've been confused for a janitor, a food service worker, even when I go in a room and I introduce myself, like always when I first walk in a room, hello, I'm Dr. So-and-so." And it's like they don't hear that. And this really served to reinforce the sense of not belonging. There's also this sub-theme that we titled "Alien in One's Own Land," and this seemed to really affect, in particular, our Hispanic and Latinx subgroup, where for people who appeared not to look American for whatever reason by others, there was often a constant questioning of credentials and other microaggressions that were noted. And so in that first quote, "Hey, can I just call you Bob?" by a Nigerian American resident who introduced himself as Dr. So-and-so, and that was what the patient's response was. And then in our second quote, we have this Mexican American resident whose family has been in the US for 4 generations. English is his first language. He described a common experience this way: "Oh, wow, that last name is different. How do I say it? Where is that from? Is English your first language? Where are you from?" They would not just accept Texas. And then this interesting theme that we called assumptions of similarity. And this was really the idea that for many of our residents, they could cite experiences where particularly faculty or even program leadership would often confuse them for other residents of color in the program, even when they did not feel like they looked anything like the other person. And so this is a surgical resident who talked about how there are 6 of us who are Black women in her program. They're constantly interchanging our names, constantly interchanging people that don't even look alike. People that it's like, "I was in your surgery. I was in your 8-hour surgery the other day. Your 8-hour surgery, and you do not know my name." On the other end of the spectrum was explicit bias, which was certainly less common, but still noted. And this was one quote, usually at the hand of patients, that this kind of language was coming from. "Someone like you should go back to where you came from. You people come and you take our places and you take our jobs, and you don't even have citizenship, and you don't even speak English." It was interesting to us as a research team to note that despite the relative frequency of these kinds of events for these underrepresented residents, in many cases, none of them actually reached the level of program leadership. In fact, many people said they often just talked about it with perhaps a spouse or a close friend or with fellow residents of color in the program, never shared it with a faculty advisor, never shared it with a program director. And when we tried to delve into what that hesitance was, there were a number of barriers, but I've put a few of them here. The first being fear of repercussions, which was especially pronounced among our interns. So one resident put it this way: "When you're at certain levels of your training, you don't have clout to really stick your neck out and say you're totally out of line." There were a few more senior residents who felt that if they had developed some type of reputation in their program as a strong clinical resident, then perhaps it would give them some leeway to broach some of these other issues. There's also a degree of skepticism that speaking out would actually lead to any measurable change. So one resident talked about bringing things up in the past and never getting a response, and that discouraging them from pursuing further reports. And lastly, there's this time and energy expenditure, which we found really compelling. This idea that being a resident is difficult enough without creating extra meetings for yourself, having to talk to leadership about a hurtful experience. And one resident put it this way: "That's the hottest piece of currency that I own in residency is my time. I don't want to spend it reliving something." Our second major theme that I'll touch on is what we termed race ambassador. And this really comes from the literature around minority tax, which again, Marcel Nunez-Smith and others have really been involved in developing as a concept. And the basic idea is that, particularly in academic environments, people of color suffer extra burdens that are often related to diversity work that happens in an extracurricular fashion. And so this may include things like going to the minority recruitment dinner, being asked to serve on diversity committee at a disproportionate level than folks who are not people of color. And what we found particularly interesting about this is that this has been pretty well established among faculty, among people who are at the attending level. However, this is the first time that it was ascribed among resident physicians, which is significant given that residents are primarily here for education and training. And so one resident put it this way: the Black people are asked to fix the Black problems. And these were in the areas of education. You know, we had folks who were actually in charge of the sort of social determinants of health curriculum at their institution with little support from faculty and program leadership. They were serving on committees, they were actively involved in recruitment, and there wasn't really a lot of structure to assist them in these efforts. We also were struck that in many cases there appeared to be an institutional abdication of responsibility around diversity and inclusion efforts, and really a lack of a strategic vision to move forward on these issues. And in some cases, institutions were relying on the efforts of a really small pool of residents and faculty to do the diversity work. And as exemplified in this second quote here, when we had our Black attending, he was very involved in recruiting minorities. So every year there was at least one. Since he's left, without that voice on the table, there's few. And so again, we see how vulnerable some of these efforts were as they were just relying on a small group of individuals, and there really wasn't much of a systemic process. And then our last major theme here is what we termed pressure to cover racial identity. And so Kenji Yoshino writes about this as kind of this idea of playing down outsider identities in order to blend into the mainstream. And so we certainly saw this with our residents. In our first example there, this is a biracial resident who wears his natural hair in a ponytail and had a clinic attendant come up to him and say, you know, there's people here who you're going to see in clinic that probably would not feel comfortable with your hair being like that. And as a result of these kinds of experiences, what we saw among our sample is that a lot of these underrepresented residents developed this sense of hypervigilance around, in many cases, external factors, their hair, the clothes that they were wearing, their speech patterns, their body language, and this kind of pressure to be perfect that developed outside of some of these experiences. And one resident put it this way: you just want to make sure that what you're doing is top notch, because they may use your mistakes and then kind of pair that with your race. And now Dr. Boatright is going to talk about some bias in professional opportunities.
Thank you so much. So Dr. Black has already illustrated some of the themes that we developed in our research looking at graduate medical education and residents in graduate medical education. But we also wanted to highlight these experiences, again, aren't just unique to faculty and aren't unique to residents in graduate medical education. And we did want to highlight a few experiences that are common in undergraduate medical education that can still impact the pipeline of minority physicians, independent practitioners. In particular, we wanted to highlight some elements that would be important for medical students making the transition to residency, and often some very important selection criteria that various programs use. In particular, we wanted to highlight some work we've done looking around racial and ethnic disparities in Alpha Omega Alpha Honor Society membership. We think this is important for a variety of reasons. Research has already shown that members of the AOA Society are more likely to match into their preferred specialty, especially competitive specialties such as urology, more likely to go into academic medicine. And as Dr. Black stated previously, we see significant disparities in representation at the faculty level. And members of this society are also more likely to obtain the rank of dean and chair. So for this study, we actually obtained approximately 5,000 applications to Yale to residency programs. These students came from all 150 accredited schools, and we obtained data including race, ethnicity, sex, age, and then also various measures of academic achievement such as USMLE Step 1 scores, measures of research productivity including publications and abstract presentations, levels of community service, leadership activity, especially on a national level, and also gold humanism membership. And based on this study using multivariable logistic regression, we found that Asian medical students were about half as likely as white medical students to be members of the AOA Society, even adjusting for all these factors. And Black medical students were about 1/8 as likely as white medical students to be members of the society, and adjusting for all these factors. So in this regard, you know, many surveys of program directors have often mentioned AOA membership as being at least in the top 10 of importance for selecting criteria. And just anecdotally, especially speaking with program directors from very competitive specialties, I've definitely heard program directors say they will only even interview applicants that are members of the society. So this disparity becomes very important, again, as a structural barrier that can actually limit diversity that we're seeing in specialties. Another structural component of the application process that we wanted to examine more and highlight was the dean's letter, or the medical student performance evaluation letter. This is a common, or it's the component of every single application that medical students submit for residency training. And what we really wanted to highlight here was just the language that's used. What's unique about the dean's letter is that it involves voices, not just from the medical school dean, but from faculty throughout that medical school, residents, and sometimes even other medical students. So we actually, again, obtained about 5,000 dean's letters from medical students across the country. And we used natural language processing to evaluate several key words that have found in previous literature in this biological sciences to show differences based on gender. And we actually looked for those differences based on race, ethnicity, and gender as well. And what we found was, when we looked at what has been termed as standout words such as exceptional, best, bright, talented, those words were much more likely to be used for white medical students compared to Black medical students. And then when we looked for differences based on gender, what we found was that women were much more likely to not be described with those same standout words, but more likely to be described as empathetic and caring. So again, even just in the language that is used to describe medical students, we can see disparity that may have impact on the ability to match into training programs. And again, we feel that this may impact this distribution that we see in academic medicine, where again, we see an overrepresentation of white faculty, both at the assistant, associate, and full professor level, and diminishing representation of minority faculty as we move through assistant professor to associate and full professor. And again, there's been ample literature to demonstrate various reasons for this and just this phenomenon as well. Again, this is a study that was published by Dr. Nunes-Smith here that looked at institutional variation and promotion of faculty across US medical schools nationally. And essentially what she found was 13% of all institutions in this country did not, for an academic year, promote any Hispanic faculty from assistant to associate professor. 24% of institutions did not promote any Black faculty from assistant to associate professor. And 33% of institutions had, only 33% of institutions had equitable rates of promotion. I'm now going to turn this back over to Dr. Black to discuss why diversity in healthcare matters.
So one of the main reasons when we kind of start to think about why this is an issue we should be engaged with as a medical community, I think, is understanding what some of the benefits are that are related to having a diverse community. And a lot of the literature around diversity comes from the business literature. And there is one study that was published back in the 1990s that is thought of as kind of a landmark study in the way that it demonstrated that diversity leads to increased creativity among group work and among teams. And so this was an interesting study where there were 135 volunteers, college students, who were paid for their time. And they were asked to do a task which was called the brainstorming problem. And the idea here was to solve the idea of US tourism and come up with as many ideas as possible to improve tourism in the US. And those were sort of their guidelines. They were broken up into two groups. One group was a fairly homogenous group in terms of race and socioeconomic status. The other had a wide range of folks from different walks of life. And then there were blinded judges who assessed these two groups on the basis of the feasibility of these ideas and also the level of effectiveness. And what they found was that both in terms of feasibility and effectiveness, the high diversity group was found to perform at a much higher level compared to the more homogenous group. And similar findings have been replicated by multiple other studies.
And just to describe a little bit more of the business literature, this is actually a study that was recently published from McKinsey that actually demonstrated looking at businesses that are in the essentially Fortune 500 that have the most diverse boards actually also had better market performance in terms of profits, return on equity, and return on investment. Previous literature that Dr. Black described seemed to suggest that these benefits from creativity and performance come from diverse groups having different perspectives and consequently being able to solve problems more effectively. And the author of these papers had a similar conclusion, but they also brought up the fact that not only are diverse groups able to solve problems better because of a variety of perspectives and backgrounds and different approaches to tackle problems, but they also said that diversity actually gives you the truest level of market competition, such that you're actually hiring and including the best people. The idea was that when you look in a room, if everyone looks exactly the same, you have to ask yourself if you really are drawing talent in the most and largest pools possible. And obviously, while creativity is important, obviously in terms of the research we do, in terms of the way we approach clinical problems, and obviously since we are to some degree in a business, profits are important. I think the key outcome that we're looking for here is patient care. And also there have been several studies showing the importance of diversity also in the healthcare workforce on patient outcomes. In particular, when looking at race ethnicity, multiple studies have showed that increasing diversity is very important to improving access to care and quality for patients. Recent studies have shown that non-white physicians actually care for approximately 50% of all non-white patients and 70% of all non-English speaking patients, especially when you look at the primary care fields. And then in terms of moving forward, we just wanted to also speak about some institutional next steps that we would advise programs to take both on a national level and also identify some institutional steps we're taking here at the Yale School of Medicine. So going back to some of the results that Dr. Black mentioned from her qualitative study, we felt that many institutions currently lack a true strategic plan and a true level of engagement and responsibility for promoting diversity efforts. We feel like excellence in diversity doesn't just benefit minority physicians and patients, but benefits the entire country as a whole. And consequently, we view excellence in diversity as an institutional priority. Additionally, we feel that institutions can minimize burdens placed by minority groups by allocating more resources, be that in terms of time and funding to promote diversity activities, and also more sufficiently integrating diversity, equity, inclusion efforts into the mission of the organization as a whole. In terms of some institutional next steps that we would recommend, one common intervention that's currently being practiced are mandatory unconscious bias training programs. These are things such as taking the implicit association test just so people can have a baseline understanding of the biases they have currently. Interestingly enough, current research actually is mixed as to whether or not this is effective long-term in terms of changing people's implicit biases. That being said, we still think it's an important initial first step for many organizations to at least start to develop a conversation around these issues. We think scheduling open forums to discuss issues of diversity and inclusion are important. Again, often as Dr. Black mentioned in her study as well, when people experience instances of bias and discrimination, those instances often are rarely reported up in the administration and leadership, and these open forums will give an opportunity to really give everyone an opportunity to understand what the true climate is at the institution. Along the same lines, we advise institutions to have routine monitoring of instances of bias and discrimination, to have more transparent data along this issue so it can be tracked and improved upon moving forward. And then we also encourage programs to develop a strategic plan to increase diversity in their own institution. And then finally, we again, I encourage institutions to support colleagues, both white and minority, that are interested and engaged in diversity work, such that people have adequate funding, administrative support, and protected time. When we look at initiatives that are going on currently at the Yale School of Medicine, currently there is a diversity representative present on each faculty search committee. In 2016, the School of Medicine hired a chief diversity officer, it's the school's first chief diversity officer, and that's Dr. Dore Lattimore. And Yale New Haven, the hospital system, hired its own first chief diversity officer, Lizette Martinez, in 2015. We also have the Minority Organization for Retention and Expansion for minority faculty to develop a system of support and community. And in 2015, the Yale University as a whole implemented a $50 million diversity initiative to help recruit from diverse backgrounds. Many departments, including internal medicine, have also identified a chief diversity officer to represent that particular department. In addition, many departments are also incorporating and developing diversity committees. And if this department were interested in that as well, Dr. Black and I could definitely give some successful strategies to to develop that committee. And then last, we just want to focus on some individual actions we can all take to help promote diversity and inclusion in our specific institution. So again, just being aware of your own personal biases. And again, we all have blind spots regardless of our background. Additionally, knowing your program's metrics for trainees, performance and using them, again, even going back to how medical students are selected for residency training, if those selection criteria are known to incorporate structural biases, figuring out strategies to identify them would be helpful. And then finally, practicing mindfulness about the strategies we use and the biases we have, and then sharing the diversity work within your department, and then also recognizing that we don't operate in a silo and that many departments are trying to identify strategies and practices along this same spectrum, and that we can work as a collective to improve diversity here on campus. Now I'll turn over to Dr. Black just for some closing thoughts.
So just as we wrap up here, and we're happy to take your questions shortly, I think something that should be highlighted is that when it comes to the matter of inclusion and diversity, I think ultimately a lot of this boils down to a wellness issue. I think particularly when we look at the workplace environment of trainees, both students and residents, it I think is clear to see how much of this can affect academic performance and feelings of fit in a program, and likely have downstream effects later on in terms of their trajectory in the medical field. And so something we feel strongly about is that these issues around representation and experience are very much interdependent. I'm sure you can imagine that if there's a suboptimal climate, it becomes very difficult to recruit people of color into an environment where the underrepresented trainees are already having a difficult experience. And we also know from the literature that high diversity medical schools actually have been shown to decrease students' level of implicit bias. There are many reasons to think about why improving our climates and our representation stand to have long-lasting effects. As we wrap up here, we've shared a lot of data with you and shared a lot of stories, and we hope that you'll just take a minute and silent reflection to think about some of the things that you've learned and seen in our talk this morning. And whatever step that comes to mind for you, maybe it's thinking about how to formulate a diversity committee, maybe it's revamping an interview process in a way that mitigates bias, maybe it's talking to a colleague who looks different than you about some of their experiences at work, or speaking up when you hear when a faculty member say an inappropriate comment. Whatever it is, small or large, if there's something that you can take a moment just to identify as something that you can do as a result of what you've heard today to make a change in this area. Some resources we wanted to highlight. So UCSF has a fantastic unconscious bias website. If you just click UCSF unconscious bias, it'll come up as a first link. And there are many studies there where you can learn more in terms of the social science behind unconscious bias, and also do some training modules around mitigating bias. We also wanted to point your attention to the AAMC portal on physician workforce trends, which gives a pretty comprehensive understanding of not only where we are currently in terms of race, ethnicity, and gender, but also where we've come from, and kind of highlight some of the work that we need to do to make our healthcare workforce more closely represent the diversity of the nation that we live in. And lastly, as Dr. Boatright alluded to, Project Implicit, also known as the Implicit Association Test, just an excellent tool that we have to become more aware of our personal blind spots as a starting step. We just wanted to acknowledge multiple people on our research team, as well as our study participants and those who helped us in terms of gaining an understanding of some of the literature. And with that, we are happy to take your questions. Thank you.
Medical students across the country.
One more time.
The representation percentage-wise of minority
The Northeast, or in the country
medical school students.
for underrepresented medicine, I believe is somewhere around 20%. Yeah. Yeah. The rest underrepresented. Here at Yale, it's somewhere around 25%, I think, at our undergraduate campus. And remembering, of course, that those groups comprise about a third of the nation. So,
good talk. Have you looked at diversity in the various residency programs here, and to see, which programs were doing "quote unquote" well, and those who haven't? And and this may be a biased opinion, but having been here for a number of years, I would say that urology is, we've had a quite ethnically and gender specific diversity over the years. And maybe to learn, and that may not necessarily be true. I mean, compare it to other programs, I don't know, but and to try to find out, what works and what doesn't.
yeah, I think that's an excellent point. I do not know of any studies to date that look at that specifically here at this institution. I think many of us who do diversity work have a sense of which programs probably have best practices or who are have been more successful in terms of URIM recruitment. I think your point is well taken to examine that more closely and see, as Dr. Boatright talked about, I think a lot of what happens is, if people are doing diversity work in one department, they're often not aware of what's happening in a different department, and there should be a lot more collaboration. So I think that would definitely.
Thank you for this talk. The slide where you showed the proportion of underrepresented in medicine minorities in the medical school, residency, and then amongst academic faculty. If you go back in time and look at those trends 10 years ago, 15 years ago, to kind of see if, is this a projection of the changing makeup of our faculty over time, or is there truly a disproportionate track of underrepresented in medicine individuals going into academic medicine, or are they choosing private practice or hospital-based practice for financial reasons, interest, things like that, or exclusion from faculty? Or is this something that in 10 years, when we look at these numbers, those residents will now have a proportionate position in academic faculty?
Sure. So there have definitely been changing demographics and proportion, especially women and underrepresented minorities in medical school over the last probably 30, 40 years. That being said, this trend really has been persistent. I think one way that you can really see how persistent the trend is if you actually look at the percentage of women. So if you look at 1970, for instance, the percentage of women in medical school is about 20%. And we're just now getting to the point where the percentage of women in medical school is approaching 50%. That being said, when you look at the percentage of women that are faculty in academic medicine, only about 30% of all academic faculty are women. So I think this trend is very persistent. That being said, there are changes that are occurring, but these changes are modest. So if you look at 2009, the Liaison Committee for Medical Education introduced a diversity accreditation standard. And that has had significant impact for women in medical school, and then we're seeing modest gains for underrepresented minorities. So I do think we are going to see some downstream effects in graduation. And GME, actually, or the ACGME rather, has just released its first diversity accreditation standard this year, such that all GME programs are now going to have systematic policies and practices in place to promote a diverse workforce. So hopefully we'll see changes at the GME level nationally as well. That being said, studies do show that at the GME level, underrepresented minorities are about 30% more likely to withdraw from residency training than their white counterparts, and similar numbers among women as well. Studies of faculty at the of underrepresented minorities and women also show that underrepresented minority faculty and women are much more likely to leave academic medicine as well. And when we look at the reasons, a lot of those reasons have to do with feeling a lack of community, experiencing discrimination, and feeling that they don't have institutional support. So I think while the trends in terms of the numbers in the pipeline are improving, I think we still have work to do on the climate as well.
Yeah, since 1960.
So I want to comment what you were saying earlier about using residents or faculty as ambassadors. I think you get caught in a little bit of a tough spot a small program, you can swing very widely. So one year we had 2 women that were African American. We had a lot of women's program and a lot of African Americans, 25% of our program. But 3 years later, when they graduated, that was a huge hit. We lost 25% of our class. And same with faculty. When we were a small faculty, we went up to 30, now it became less than 10%. Folks leave, it gets even smaller. So now you're forced to, if you want to have representation, you have to residents and all here as ambassadors. I know there's a out or a little bit of a hard stop.
Yeah, I do think it's a tough balance. I think, you know, I can remember being on the interview trail, a lot of programs would sort of showcase the fellow African-American residents in their program, and it was helpful to connect with them. But I don't think the message is that underrepresented trainees can't be involved in the process. And I think, in fact, in our study, what we saw is that a lot of folks actually derive some personal satisfaction from helping this issue that they tend to feel pretty strongly about. I think the key is identifying ways to support that at an institutional level. So, for example, many of the residents through GME, in internal medicine and other specialties, have been involved in doing minority recruitment efforts, going to, you know, national conferences where there are a lot of underrepresented in medicine trainees, and trying to create a pipeline that gets out the Yale name and makes folks more likely to apply to residency programs at Yale. And something the GME office has started doing this year is offering moonlighting money and just administrative support to help offload the responsibility of a resident having to identify someone to cover their shift, go to this national conference, which is really for the organization to help improve diversity. So thinking about it not just as the individuals doing this thing in their own time, they have to, you know, book their own flight and get their own hotel and figure out how to get their coverage done and all of these kinds of administrative tasks that happen even though they're doing the work for the institution, but rather creating structures where that work is supported. So I think that's kind of the message I think we're hoping to send is, one, you know, how can we all share in this work? So even people who are not from underrepresented groups can certainly still speak to diversity and inclusion. I think it actually sends a really strong message when there are people who are not of color who are talking about diversity, and really send a positive sense of collaboration and investment in diversity when it's not coming from people of color.
And to add to Abba's point too, I think one of the themes that you brought up was just the fact that residents are only here for a limited amount of time. And that other resident that made the comment that when we had a diverse faculty member, there was always some representation. So I think this kind of goes back as well to, while definitely recruiting the represented residents is important, there might be even more important in terms of recruiting minority faculty, because theoretically they're going to be here for an indefinite period of time. They can be present and kind of signal to even applicants, even just looking on your website, that the institution is supportive of diversity, and potentially that might be an area of greater concentration as well.
Shocking to me, and thank you for highlighting. I wasn't aware of that. I'm just curious, has the AOA responded to that? I mean, that's really shocking, because we're about to go on into interviews on Monday, and that is definitely like one of the boxes we look at. Oh, that person's AOA. The fact that controlling for academic achievement and scores and grades, there's a persistent disparity. I don't know, do they have a response to that, or? Probably, yeah.
So they've been slow moving without question. So, right, I can give you a long history about this actually. So right before that study was going to be published, we actually contacted the executive director of AOA, and I didn't hear anything back. So then I wrote a couple more emails. Mainly it's just like, I don't want to embarrass anyone. The study's coming out, and didn't hear anything. And then the study came out, and I got an email from the executive director. And I was like, the email was great. He was like, oh, this is really important. We should talk about this. I'm like, oh, this is phenomenal. So I spent the whole morning writing up some notes about potential strategies. And when we spoke on the phone, the director kind of gave this long talk about how important diversity was, how every AOA program advisor has to undergo some type of bias training at a conference they do once a year. And then I was like, great, well, what do you think about these potential strategies? And then he was like, we're a very small organization. We don't have much money. We're not going to be able to add any new initiatives. And that was essentially the end of that conversation. That was back in 2017. But then I think things have slowly started to change recently because Mount Sinai actually elected to suspend their AOA chapter. So they actually looked internally at their own data and found that only about, I want to say in the last 20 years, maybe 4 underrepresented minorities had been elected to AOA at their institution, despite Mount Sinai being one of the more diverse medical schools in the country. So they suspended their chapter and reported that to AOA, and AOA became reasonably concerned that they were suspending their chapter. And I think there's still some internal dialogue going on now about what they can do. One of the first things they did was they actually did make an award for AOA chapters that had demonstrated diversity. But again, I'd say that's a pretty modest step. I think there still needs to be some more structural change that goes on and more investigation as to why this disparity even exists. But I think they're moving very slowly, but I think they're getting to a point where they can't ignore it anymore. Yes, so Harvard doesn't have AOA. I want to say Mayo doesn't have AOA. Brown previously didn't, but they recently adopted a chapter, and I want to say Stanford's the same. So it may just be Yale and Harvard. And Yale historically did have an AOA chapter. And when I spoke with Dr. Anghoff, she told me the reason they eliminated it was because there were never any women elected.
Thank you so much for your talk. I have a question kind of from the applicant side of things. So at Loyola, I was fortunate to be in one of the most diverse classes in history. At the university, there were about 25 African-American students, 40 total underrepresented in medicine in my class. And so over time, there kind of became this feeling of, you were let in, they cherry picked you from a list, like those sorts of things throughout my medical school training. And so I was wondering, kind of crossing over into the resident world of things, how do you, what strategies are there for programs when they're choosing, underrepresented applicants to prevent that sort of, you were on the list or you were cherry picked because they needed Black students or they needed underrepresented students?
Right. So I think one thing goes back to what Dr. Black mentioned too, in terms of just identifying the metrics that you use to identify residents going to be successful in your system. So when I was a resident at Denver Health, before I arrived, I think there'd only been one other resident of color in about 20 years. And we started looking at the data, trying to figure out why there were so few residents of color at Denver Health. And we looked at the metrics that students were used for selection, and they were all the traditional metrics, your GPA, your STEP scores, things like that. And when we actually started talking about the actual mission and values of Denver Health, which is a community hospital, none of that was in alignment. So, Denver Health ideally wanted to train people that were going to give back to underserved patients. So part of what Denver Health began doing at that point was actually, instead of just focusing, still looking at board scores, it was still a component of the process, but using a more holistic admissions criteria such that we actually look for medical students that would come here, be residents that actually wanted to serve in an underserved community. So we looked at volunteer activities, who had done, if you work at a homeless clinic. And we looked for actual people that didn't just, this is a checkbox, doing leadership roles there as well, such that we weren't just matching applicants that had board scores, but we were actually matching applicants that we felt would fit in and with the community at Denver Health.
I'll just add that there have been studies looking at factors which tend to predict resident performance, and things like STEP scores and transcripts actually have very little correlation to who ultimately ends up being a strong resident or even, in the role of a chief resident. Interesting, the Gold Honor Humanism Society, and I don't know if there's bias in that selection, but that seems to correlate a little bit more closely with what someone will do, which kind of makes sense because the Humanism Society is all about kind of person-centered care and interprofessional characteristics. I'll just add that something I'm working on in the primary care internal medicine residency program along the lines of a holistic review process is sort of isolating our interview so that it really speaks to whether or not that person from that conversation seems to be someone who embodies the mission. And so we have a very clearly written out mission statement. I think something that we recognize is what are we doing with the mission statement when it comes to the application process. And so now we've kind of semi-blinded our interview process. So when the faculty are interviewing these applicants, all they have is their personal statement and their CV. And we've developed a list of suggested questions for the interview, which people are allowed to deviate from, but essentially it gets at the ideas of mission, of social justice, which is very important to us as a program, of resilience, of inclusion. And then of course, the other components still factor in when the resident is taken, or the resident applicant, we're looking at them as a whole, but the interview is really standing for the interview, which is more about interpersonal characteristics. And so to your point about avoiding the kind of perceptions that sometimes arise, I think one thing to note is that there's a very stringent screening process that occurs even before people get invited for an interview. And so different residency programs do it differently, but no one is invited to interview if they're not thought that they could sort of do the academic work. And then all these other things are taken together.
Just one more point about holistic review too. I haven't seen any studies at the graduate medical education level for holistic review, but there was one large study that came out for undergraduate medical education 5 years ago. And it had a control group of medical schools that did not use holistic review, that just used the traditional metric, primarily being MCAT scores and GPA. And then a control group that did use a holistic method and still had, again, MCAT and GPA as a component of that. And interestingly, based on the hypothesis, the programs that did use holistic review actually were significantly more diverse based on matriculant, gender, and race ethnicity. But interestingly, when they looked at the GPA and MCAT of those schools that did holistic review, they went up as well. So again, it was this idea that diversity actually isn't increasing any of those traditional metrics. It's more or less drawing greater talent from a larger pool.